Good afternoon. Thank you, Madam Chair and Vice Chair. I am pleased to be here today. My name is Carrie Kroll. I'm the Vice President of Advocacy, Quality, and Public Health for the Texas Hospital Association. And I'm here this afternoon on behalf of Alan Harrison. I'm testifying on myself, but he was going to be here for Methodist Healthcare Systems in San Antonio, which is a co-owned partnership between Methodist Healthcare Ministries and HCA Healthcare, which is one of the largest providers of healthcare in Central and South Texas. There is another group of cruise ship passengers that are on their way to San Antonio, and so as of last night, he called and indicated it would be better if he stayed at the helm of his facility to prepare for those individuals rather than be here. So I will walk you through a little bit of their experience, being one of the first, one of the hospitals to treat the first case of 2019 novel coronavirus in their facility. They're getting used to these cruise ship evacuees. So the patient was evacuee from China in quarantine at Lackland Air Force Base, was found to be symptomatic. The facility closely coordinated with EMS, the city, the CDC, STRAC, which is the Southwest Regional Advisory Council, and many other key leaders prior to receiving the patient. And it was extremely orchestrated, if you can imagine that, methodical effort that went into putting forth resources to prepare. The facility activated strict protocols prior to the patient's arrival, planned for security and for other measures to protect the healthcare patients and staff. Because it wasn't your typical patient, and they knew that as it was coming in. The facility provided care in negative pressure room and followed strict CDC guidelines for staff getting suited in and discarding protective gear. So for every step, the hospital had a third individual observe and closely follow a checklist to verify that all the steps were taken. Texan, the hospital used video surveillance to study, monitor the donning and doffing of personal protective equipment, and the room has a specialized dedicated exhaust system that generates airflow going outside of the room away from the hospital. Hospital staff and leadership was phenomenal during this. Obviously, it was a heavy lift. Employees volunteered to be part of the care team in advance of the patient's arrival. Texan unfortunately did have some patients cancel scheduled procedures during this time for fear. A situation involved incredible amounts of work, as you can imagine, communication, coordination on the front end to ensure the hospital was ready to proceed to accept the patient and able to provide that level of care. So our hospitals exercise these scenarios regularly, and this was no different. They activated their incident command structure last week and continue to develop additional plans, and it has taken a large level of engagement among all their leadership and staff. They continue in that instance to be, as we've heard from other colleagues, concerned about surges in demand for testing, PPE shortages, staffing, and other issues that I will speak to a little bit more in depth. With regard to treatment of this particular patient, the hospital was very transparent with staff, and there was a level of calm sense of pride of those on the team that were being called to provide this level of care. It is unique and special experience that frontline staff have, obviously, that they won't forget, but it's a lens into the future hospital care that, should the coronavirus count dramatically increase, which through community spread we expect will happen, we'll take all kind of hands-on-deck approach. And HCA was ready. Though it was a tremendous strain, they provided that organized care. Coronavirus does, though, have the potential to threaten our ability to keep Texans safe due to the extreme pressure it's going to place on the healthcare system. The situation for Texas hospitals is concerning, given we've had a significantly challenging flu season. We've talked about that already today. But there's also an uncertain financial landscape in front of us due to recent federal actions related to supplemental payments, new proposed regulations, and coronavirus comes at a time when hospitals are already overstretched. So today's focus on coronavirus and our collective mission, it will get better before it gets worse. We've certainly heard that. But the good news is the most people that get infected won't become seriously ill and will not need hospitalization. But as those that are seriously ill do need hospital care, including respiratory support, most hospitals in the state do not have extra capacity. Okay, so we're not holding on to beds just for COVID-19 patients. We will continue to provide that planned care. So if you think about cancer surgery, knee replacements, and other procedures, as well as the urgent care that we provide for people experiencing stroke, heart attacks, or serious accidents, in addition to the special care that we provide at the beginning and end of life. None of that's going to change as we take on this public health crisis. Hospital space will need to be made available quickly in an emergency or with a surge of critically ill COVID-19 patients. But we have to seriously consider this important fact that, if nothing else, healthcare is a precious and finite resource that must be preserved for those who need it most. It must not be depleted, and it can't be squeezed to the point in which it can't exist or our quality suffers. We want to continue providing that high level of care. So we aren't, challenges, or we're familiar with that in the hospital industry. We are in this together. There are several concerns hospitals have during this time that I'd like to highlight for you so that you're aware of the complexities experienced by the healthcare system with regard to COVID-19. For example, how do we speed up the turnaround time on testing? And when will we see widespread testing capabilities? We know it's coming. When is that? Current delays are impacting patient care and have the potential to impact disease transmission. How can we protect our nurses, our doctors, our other frontline staff, and manage the fact that there are extremely limited supplies of masks and gowns? How do we care for the uninsured? How do we ensure that there are resources to follow up with patients who have been discharged and are isolated at home? How do we make space for new patients who may be experiencing difficulties? If we have experienced difficulty in discharge patients to long-term care facilities, we know our partners in Washington are having that problem right now, our hospital partners. How do we maintain our ability to respond to those true emergencies when emergency departments are filled with people who want testing or treatment for mild respiratory symptoms? And how do we stay fully staffed when our healthcare workers contract COVID-19 and must remain quarantined? So we're working through these questions with each other, seeking guidance from every level of government, public health, but the nature of the situation is changing rapidly, and there are many, many gray areas. To help with that work, I'm pleased to say that the Texas Hospital Association has launched a COVID-19 task force in coordination with the Texas Department of State Health Services. Our goal is to ensure that Texas hospitals have the resources they need to effectively manage the outbreak and put the health of our patients and healthcare workers first. The task force will work through the most pressing issues as they're identified. And just to give you a little bit of idea where we will start at our first meeting on Thursday, we know that there's additional people being transported to Texas from the Grand Princess cruise ship in California. Knowing this, we have a critical need for increased coordination between the federal government, state government, Texas hospitals. We have to be able to forecast these surges so that we can prepare for potentially dramatic increases in the number of acutely ill patients in Texas. Improving the fast turnaround times on testing and more testing capabilities. The supply chain issue, making sure that they are flowing for PPE and other medical supplies. Flexibilities that we may need regarding certain regulatory requirements, financial support to cover those extreme costs that may be associated with COVID-19, and then help with public education, because the truth of the matter is there are people today, right now as I'm talking, going into their hospital and asking to be tested for this disease. And so we really want to make sure that people know the emergency department is not the place to go unless it is an emergency. And so we know that our state handles these outbreaks and other challenges with grace, leadership, and strength, and we protect and save lives every day, and we try to collaborate, and our hospitals are taking steps now to ensure they are ready, and we are honored to be a part of this team in Texas, and I'm happy to answer any particular questions that you may have, and I'm happy to respond to Chair Leach's question about telemedicine, if it's appropriate for me to do that now, or telehealth.
I don't think we have any questions. I don't see anybody. Oh. Representative Allison?
Yes, sir.
I just wanted to follow up on the personal protection equipment. I know you've identified that as a problem, but what's the plan to address it? As I understand from the state earlier today, it's currently the responsibility of the individual facilities.
So I think what's unique about how we've responded in the past as an industry is that we have been able to share resources, right? Or we have systems that are in other states where, in the instance of Hurricane Harvey, for example, they could send us their healthcare workers or their masks or their gowns when we needed assistance. They could help like that. And everybody's going to be strained in this scenario. We're not getting a lot of good guidance because there's not a lot coming. What we do know is that from our federal partners, there's an emphasis on trying to improve the manufacturing of product. I think there's concern about how much you can effectively manufacture when a lot of the even core components that go into making these products come from China. And so, how does that slow the system? I think that's the real threat, is when and where we will get those. Even our colleagues that we hear from Washington State, that are dealing with a more significant community spread right now are being, are warning us, and that even when the national stockpile was open for them, it's very small amounts, right? Because it's a national stockpile, it's not just a Washington stockpile. So we can't count on the fact that that's going to happen. It's going to take some innovation as I think U.S. manufacturers and others try to figure out how to provide more supply. Until then, we're really pushing out to our members the guidance that exists about how do you reuse, how do you smartly take care of the quantities you have, how do you reuse them appropriately, and then even in areas where I'm sure my colleagues to the left have quantities that are expired. The CDC is working on revising that guidance to say, if it's expired and it looks like this is how you can use it, with the thought that you keep what you have supply for the most acutely ill, to keep that protection, and then try to backfill with whatever is left.
Even for this type of equipment, we're that dependent on China?
Sadly, it's a good argument for American-made products.
It sure is. How about that? I know in San Antonio it's going to become an acute problem if the problem increases, and that's bed shortage. We have bed shortage right now. So what, are there discussions ongoing how to address that if that becomes a situation?
There is, and I envision that'll be something that our task force talks about, which is how do you think of novel ways of standing up bed capacity. If it's that you couple acutely ill patients in one facility while keeping another facility available to take full care of people who may not be as ill. There's that basic idea of shuffling, but also things like, for example, what you saw in H1N1, which was you could do a pop-up sort of emergency style tent where you're triaging patients that aren't that ill, getting them tested, getting them the basic care that they need, and then moved out of the hospital to free up. I mean, it's going to take a combination of those things. What DSHS did with the Texas Center for Infectious Disease was fantastic. You know, they had bed capacity there. They've been able to turn it on for patients that need care but aren't that acutely ill, those kinds of things. I think it's just going to take that continued cooperation to make sure that we have the capacity we need when patients start to show up more frequently.
Okay. Thank you.
I hate to ask this question because I should have asked it when it was presented, but I heard something. Did I hear monkeypox?
That was me. Yeah.
What is it?
It's just another infectious disease that we see with kind of rare. It's similar to smallpox.
Oh.
But we see it with rarity, and there are occasionally cases in various places throughout the world. But it's something that we're always thinking could rear its ugly head.
Does
So
it come really from the animal itself?
I
monkey?
believe so.
Okay.
But I'm not an infectious disease expert. I'm just an ER doc. You know, I just do what I'm told.
Just stated a holiday, yeah.
Thank you so much. Members, are there any further questions? Thank you so much.